Good morning, and I need you to stop whatever you are doing right now and give me your full attention for the next few minutes because what I'm about to share with you today could be the most important thing you hear this entire year. I want you to imagine something with me. You are sitting in your doctor's office, your blood pressure looks good, your cholesterol numbers are in range, your doctor smiles, renews your prescriptions, and sends you home. Everything seems fine. But what if I told you that inside that little pharmacy bag you carry home every month, there may be 1, 2, or even 3 medications that the latest research is directly linking to an increased risk of heart attack and stroke in adults over the age of 60? Not rare medications, not obscure drugs, pills that tens of millions of seniors in this country take every single day without question, without warning, and without knowing what the science is now telling us about what they do to the aging cardiovascular system. My name is Dr. William, and I have spent the last 27 years working directly with older adults who are managing chronic conditions, cardiovascular disease, and the long-term consequences of medication use. And what I am about to share with you in this video is not designed to frighten you. It is designed to inform you, because an informed patient is a protected patient. I am going to walk you through 5 specific categories of pills that the research has flagged as carrying elevated cardiovascular risk for seniors over 60, explain exactly why each one creates that risk inside the aging body, and give you the specific questions you need to bring to your next doctor's appointment. Stay with me until the very end, because the 5th one on this list surprises almost everyone, and it is something I guarantee you have never been warned about directly. Let me begin with a patient I want you to meet. His name was Raymond, a 73-year-old retired firefighter from Columbus, Ohio. Raymond had been healthy most of his life, strong, active, proud of the fact that he took very few medications compared to his friends. But 3 years before I met him, his doctor had prescribed him a common over-the-counter pain reliever at a consistent daily dose to manage the arthritis in his knees and lower back. It was a medication Raymond could buy at any pharmacy without a prescription. He took it faithfully every morning with breakfast because it worked. His pain was manageable. He felt functional. He felt like himself. 14 months after starting that daily habit, Raymond had a mild heart attack. He was lucky. He recovered. But when he came to my office during his rehabilitation, he sat across from me and asked me the question I have heard hundreds of times in my career. He said, "Dr. William, I was just taking something for pain. How did this happen?" What Raymond did not know, and what his original prescribing doctor had not explicitly communicated, was that the medication he was taking every single day belongs to a class of drugs that the FDA has now placed a mandatory black box warning on specifically because of the increased risk of heart attack and stroke, a risk that climbs with age, with daily use, and with dose. Raymond's story is not unusual. It is happening every single day to seniors across this country, and it is the reason this video exists. The first category of pills I want to talk about is NSAIDs, which stands for non-steroidal anti-inflammatory drugs. This is the category Raymond was in. NSAIDs include medications like ibuprofen, which you may know as Advil or Motrin, naproxen, which is sold as Aleve, and a prescription-strength version called celecoxib, known as Celebrex. These are among the most commonly used medications on the planet, and for good reason. They are effective at reducing inflammation and managing pain. But here is what happens inside the cardiovascular system of a person over 60 who takes them regularly, and why the risk profile changes so dramatically with age. NSAIDs work by inhibiting enzymes called COX-1 and COX-2, which are responsible for producing inflammatory compounds in your body called prostaglandins. When you reduce prostaglandins, you reduce inflammation and pain. But prostaglandins also play a critical role in maintaining the health of your blood vessel walls and in regulating how your kidneys manage sodium and fluid balance. When NSAIDs suppress prostaglandin production consistently, 2 things happen in the aging cardiovascular system that create serious danger. First, the blood vessel walls lose some of their natural protective flexibility and become more susceptible to the kind of platelet aggregation, meaning clumping together. That is the direct mechanism behind most heart attacks and strokes. Second, the kidneys begin to retain more sodium and fluid, which raises blood pressure in ways that can be dramatic and unpredictable in adults whose cardiovascular system is already operating with less reserve than it had at 40. A meta-analysis published in the British Medical Journal reviewing data from over 446,000 patients found that regular NSAID use was associated with a 19% increased risk of heart attack, with the risk being highest in the first week of use and remaining significantly elevated with ongoing daily use. For adults over 60 who may already have underlying cardiovascular risk factors, that number is even higher. The FDA's black box warning on NSAIDs, added and strengthened in 2015, states explicitly that these drugs increase the risk of serious cardiovascular events, including heart attack and stroke, and that this risk may occur early in treatment and may increase with duration of use. If you are taking ibuprofen, naproxen, or any NSAID regularly for pain, especially if you are doing so daily, that is a conversation you need to have with your doctor today. There are alternatives for pain management in seniors that carry a significantly safer cardiovascular profile, and you deserve to know what they are. The second category I want to walk you through is something that will genuinely surprise many of you because it sits in the medicine cabinet of almost every household in America and has been considered completely safe for generations. I am talking about decongestants, specifically those containing pseudoephedrine or phenylephrine, which are the active ingredients in many common cold and allergy medications, including certain formulations of Sudafed, Dayquil, NyQuil, and dozens of store-brand cold relief products. These medications work by causing the blood vessels in your nasal passages to constrict, which reduces the swelling and congestion that makes it hard to breathe when you have a cold or allergies. But here's the problem that the aging cardiovascular system faces when these medications enter the bloodstream. The vasoconstriction, the vessel tightening, does not stay neatly localized to your nasal passages. It is a systemic effect. When pseudoephedrine or phenylephrine circulates through the body of an older adult, it causes blood vessels throughout the entire cardiovascular system to constrict, and it stimulates the heart to beat faster and with more force. In a 35-year-old with healthy elastic blood vessels and a strong cardiovascular reserve, this effect is manageable and passes quickly. In a 68-year-old whose blood vessels have lost elasticity, whose heart may already be managing some degree of hypertensive stress, and whose autonomic nervous system no longer regulates cardiovascular response with the same precision it once had, that same effect can cause a dangerous spike in blood pressure and a significant increase in the workload placed on the heart. Research published in the American Journal of Medicine found that pseudoephedrine use in adults with pre-existing hypertension caused clinically significant increases in systolic blood pressure and heart rate that lasted for hours after a single dose. For a senior with a history of elevated blood pressure, even one that is currently well controlled with medication, taking a standard cold medicine containing a decongestant can temporarily push blood pressure into a range that dramatically elevates the risk of a cardiovascular event. This does not mean you can never treat a cold. It means that the next time you are standing in the pharmacy aisle looking at cold medications, you need to look for options specifically labeled as decongestant-free, and you need to tell your pharmacist what blood pressure medications you are currently on before you choose any cold or allergy remedy. I want to stop here for just one moment because if this video is giving you real, valuable information that you wish someone had shared with you earlier, I want you to take 1 second right now and subscribe to this channel. Every single week, I bring you research-backed health information specifically designed for adults over 60. Information that fills the gaps in what a 10-minute doctor's appointment can cover. One click. It costs you nothing. And it means you will never miss another video like this one. Now let us continue, because we are only getting to the part of this list that surprises people most. The third category is one that I have to approach carefully because I know it is going to be uncomfortable for some of you. I am talking about a specific class of diabetes medications, particularly older generation sulfonylureas, which include medications like glipizide, glyburide, and glimepiride. These medications are prescribed to lower blood sugar in type 2 diabetes by stimulating the pancreas to produce more insulin. They have been in use for decades, and for many patients, they are effective at managing glucose levels. But here is what the cardiovascular research on aging adults has been consistently documenting over the past 15 years. Sulfonylureas work by keeping certain channels in the heart muscle cells partially closed in a way that affects how the heart responds to episodes of low oxygen, for example, during periods of reduced blood flow. In healthy younger hearts, this is manageable. But in the aging heart, particularly one that may have some degree of coronary artery narrowing that has never been formally diagnosed, this mechanism means the heart is less able to protect itself during moments of cardiovascular stress. A large-scale observational study published in the British Medical Journal comparing sulfonylurea use against newer classes of diabetes medication in older adults found a significantly higher rate of cardiovascular events, including heart attack in the sulfonylurea group. The American Diabetes Association's clinical guidelines have progressively de-emphasized sulfonylureas as first-line therapy in older adults, partly because of this cardiovascular concern. If you are over 60 and you are managing type 2 diabetes with glipizide, glyburide, or glympyride, I am not telling you to stop your medication. I am telling you to ask your doctor at your next visit whether your current medication is still the most appropriate choice given what the updated research tells us, and whether newer medication classes with better established cardiovascular safety profiles might be worth discussing in your specific case. Let me tell you about Margaret, a 69-year-old retired librarian from Tucson, Arizona, who had been managing type 2 diabetes for 11 years when she came to see me. Margaret was diligent. She checked her blood sugar every day. She had her A1C tested every 3 months. Her numbers were decent. But over the past 2 years, she had experienced 2 episodes of what her cardiologist had called transient ischemic attacks, or TIAs, which are sometimes called mini-strokes. Each episode had resolved without permanent damage, but the cumulative picture was deeply worrying for her family. When I reviewed her full medication and metabolic history, one of the first things I noticed was that she had been on glyburide for 9 of her 11 years of diabetes management. Her previous physicians had simply continued renewing the prescription because her sugar numbers were acceptable. Nobody had revisited whether glyburide was still the right choice for Margaret's aging cardiovascular system. When we worked with her endocrinologist to transition her to a newer diabetes medication class with a cardiovascular protective profile, Margaret's health trajectory changed. She has had no further TIA episodes in the 18 months since. Her cardiologist called it a meaningful clinical change. Margaret told me she wished someone had asked that question years earlier. The fourth category I want to discuss involves a class of medications used for bladder control and overactive bladder, specifically the older generation anticholinergic drugs such as oxybutynin, tolterodine, and solifenacin. These are extraordinarily commonly prescribed medications for older adults because bladder control issues affect a significant percentage of seniors and significantly impact quality of life. But here is what the research has been uncovering that most patients on these medications are never told. Anticholinergic drugs work by blocking acetylcholine receptors in the bladder muscle, which reduces bladder spasms and urgency. The problem is that acetylcholine receptors are not found only in the bladder. They are found throughout the entire body, including in the heart and in the blood vessels. When anticholinergic drugs block these receptors systemically, one of the documented cardiovascular effects is an increase in resting heart rate. In younger adults, a modestly elevated resting heart rate is not generally dangerous, but in adults over 60, whose hearts are already managing some degree of age-related stiffness and whose risk of atrial fibrillation, the most common heart rhythm disorder in older adults, is significantly elevated compared to younger people. A consistently elevated resting heart rate is a meaningful cardiovascular risk factor. Research published in JAMA Internal Medicine found that older adults on anticholinergic medications had higher rates of cardiovascular events compared to those using newer, more selective bladder medications that do not carry the same systemic anticholinergic burden. The important message here is not that you should simply endure bladder control problems without treatment. There are newer bladder medications with much more targeted mechanisms, mirabegron being the most commonly discussed, that achieve the same clinical benefit without the same systemic cardiovascular risk. Ask your doctor specifically about this. Ask whether the bladder medication you are currently taking is one of the older anticholinergic types, and whether a newer, more cardiovascularly neutral option might be appropriate for you. Now, I want to come to the fifth medication category on this list, because this is the one that generates the most surprise in my patients, and I suspect it will for you as well. I'm talking about certain herbal supplements and over-the-counter products that most seniors do not think of as medications at all, specifically high-dose fish oil supplements, certain formulations of ginkgo biloba, and vitamin E in doses above 400 IU. I understand that this sounds counterintuitive. These are not prescription drugs. They are sold in health food stores. They are marketed specifically as heart healthy. Many of you have been taking them for years specifically because you believed they were protecting your heart. And in certain doses and certain contexts, some of them do carry genuine health benefits. But here's what the research tells us about what happens when older adults take high doses of these specific supplements without understanding their blood-thinning effects. High-dose fish oil, specifically in amounts above 3 grams per day of EPA and DHA combined, has been shown in multiple clinical trials to significantly inhibit platelet aggregation, meaning it makes the blood substantially less likely to clot. In a healthy person with no other clotting considerations, this mild blood-thinning effect can indeed be cardiovascular protective. But when a senior over 60 who is already taking a baby aspirin or a prescription anticoagulant like warfarin or rivaroxaban adds high-dose fish oil on top of those medications, the combined blood-thinning effect can become dangerously excessive. Hemorrhagic stroke, which is a stroke caused by bleeding in the brain rather than a clot, is the stroke that many seniors on high-dose fish oil plus other blood thinners are at elevated risk for, and it is the type of stroke that has a particularly devastating outcome. Ginkgo biloba carries a similar concern. It is widely marketed as a memory supplement, but its blood-thinning properties are well documented and clinically significant. A study published in Neurology found that ginkgo biloba use was associated with increased bleeding risk, particularly in combination with aspirin and other anticoagulants. High-dose vitamin E in amounts above 400 IU daily has been shown in large trials, including the Heart Outcomes Prevention Evaluation Study, to actually increase the risk of heart failure and, in some analyses, all-cause mortality in adults with pre-existing cardiovascular disease, a finding that directly contradicts what many seniors have been led to believe about this supplement. And I want to be very clear about something here. The problem with supplements is not that they are uniformly dangerous. The problem is that they exist in a regulatory space where they do not require the same clinical disclosure, the same physician oversight, or the same patient education that prescription medications do. Seniors take them in addition to their prescription medications without telling their doctors, sometimes specifically because they feel like taking them is a private health choice that does not need to be disclosed. And the interactions, the additive blood thinning effects, the cardiovascular implications fall into the gap between what your doctor knows and what your body is actually experiencing. A study published in JAMA found that over 60% of older adults who use dietary supplements had not disclosed this to their physician. That gap in communication is not a personal failing. It is a systemic failure of how we talk about supplements in this country. And closing that gap starts with you walking into your next appointment with a complete list of every single supplement, vitamin, and herbal product you take, even the ones that feel so ordinary you would not think to mention them. Let me tell you about the third patient I want you to meet in this video. Her name is Dorothy, a 77-year-old grandmother of 6 from Charlotte, North Carolina, who was one of the most health-conscious women I have ever had the privilege of working with. Dorothy ate well. She walked every morning. She had been taking a baby aspirin for 11 years on her cardiologist's original recommendation. And over the course of the past few years, she had added high-dose fish oil, ginkgo biloba for her memory, and vitamin E to her daily supplement routine because she had read extensively and believed she was doing everything right for her heart. Dorothy came to me after surviving a hemorrhagic stroke that had partially affected her left side. She had spent 6 weeks in a rehabilitation facility learning to walk properly again. When I reviewed her full supplement and medication history, the picture was clear. Dorothy had been taking 3 separate blood-thinning agents every single day for at least 3 years, none of which her cardiologist had known about because she had simply never thought to mention the supplements. Her blood's clotting capacity had been significantly impaired, and when a small vessel in her brain experienced the kind of minor stress that happens in millions of people every day, her blood could not perform its normal protective function. Dorothy is doing well today. She has regained most of her function, but she looks at me at every visit and says the same thing. She says, "Dr. William, I thought I was taking care of myself." She was. She just did not have the complete picture. And now you do. So what do you do with everything I have shared with you today? I want to give you 5 specific practical steps you can take this week before your next appointment. The first thing I want you to do is write down every single pill, tablet, capsule, and supplement you take, whether it is prescription or over-the-counter, whether it is a vitamin or an herbal product, whether you take it every day or just occasionally. Bring that complete list to your doctor and ask for a medication review specifically focused on cardiovascular risk in the context of your age. The second thing I want you to do is ask your doctor directly, am I on any NSAIDs or do I take them regularly for pain? And if so, is there a safer alternative for my cardiovascular profile? This single question has changed the health trajectory of more of my patients than almost any other. The third thing is to check every cold and allergy product in your medicine cabinet and look for the words pseudoephedrine or phenylephrine in the active ingredients list. If you find them, ask your pharmacist to help you identify decongestant-free alternatives before your next cold season arrives. The fourth thing is to have a frank conversation with your doctor about whether your diabetes medication, if you take one, is still the most appropriate choice given the current evidence on cardiovascular risk in older adults. And the fifth and most urgent thing is to bring your complete supplement list to your next appointment, no matter how innocent those supplements feel. Tell your doctor exactly what you are taking and ask specifically whether any of those supplements interact with your prescription medications in ways that affect your cardiovascular risk. These 5 steps cost you nothing. They require no special equipment, no new prescriptions, no expensive tests. They require only the willingness to be an informed, active participant in your own healthcare, which is exactly the kind of patient who stays healthier, stays more independent, and avoids the hospitalizations and the frightening moments that Raymond, Margaret, and Dorothy all experienced. I want to close by saying something that I say to every patient who sits across from me for the first time in my clinic. The goal of medicine is not to manage your decline. The goal is to protect the quality and independence of your life for as many years as possible. But that protection requires a partnership between you and your healthcare team that only works when information flows in both directions, when you know what the research says, when you ask the questions that do not fit into a 10-minute appointment, when you bring your full supplement list, when you push back with curiosity rather than accepting a prescription renewal without discussion. The seniors I have seen thrive in the years after 60, in the years after 70, and even in the years after 80 are not the ones who took the most medications or the fewest. They are the ones who knew what they were taking, why they were taking it, and what signs to watch for. They are the ones who had the conversation. I want that for you today. If this video gave you one piece of information that you are going to bring to your next appointment, I want you to do something for me right now. Subscribe to this channel because every week I am going to give you more of this, more research, more clarity, more of the complete picture that you deserve and that too few seniors are receiving. And share this video with one person in your life who is over 60 and taking daily medications. You do not need to say anything. Just send them the link because the conversation this video might start could genuinely protect someone you love. Leave me a comment below telling me which of these 5 categories surprised you most. And if you are comfortable sharing, tell me which medications you are currently taking. I read every single comment, and your stories help shape the videos I make for this community every week. This is Dr. William. Your health is not a side note. It is the whole story. I will see you in the next video.